Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect Podcast. I'm Dan Carter. We're here at Countryside Equine Hospital. We've got Dr. Brown with me today. We're in the studio, treatment room 1. So today we're going back to ophthalmology.
Ophtho.
You know, and it's interesting because I think ophthalmology, a lot of people don't know they're curious about ophthalmology. A lot of people don't realize that ophthalmology is important until ophthalmology shows up in their life.
Mm-hmm.
And when ophthalmology does show up in your life, you realize like this is getting real. This is intense.
Mm-hmm.
So with that, let's kind of dive into today. We're going to talk about that that eye condition that nobody wants to hear they have, but at the same time, there is hope.
Mm-hmm.
We're gonna talk about uveitis.
Debunk some things.
Yeah. So, Dr. Brown, let's dive off into some uveitis.
Mm-hmm.
What is uveitis? Let's break this down. Let's get some Greek words in here.
So uveitis is inflammation of the uvea, which we'll just end the podcast there.
Yep. Uvea, Greek for the eye.
Yeah.
I'm going to give y'all a secret. All the listeners out there, I'm fixing to tell y'all something. If you want to be a vet, if the structure's inflamed, if you just name it and then put itis behind it, done.
Yeah. And they're like brilliant. You know everything.
If something's wrong with it and you're not sure what it is and it's not inflamed, just put apathy there.
Yeah.
That's really it. Mm-hmm. If your tendon hurts, tendonitis.
Tendinopathy, if you don't know what it is.
If your eye hurts, because they got ophthalmologists do things in Greek. Uvea is Greek for eye. We stick an itis. Uveitis.
Inflammation.
You got an inflamed eye.
Inflamed eye, exactly.
So you got that and apathy. Know that you don't give banamine in the muscle, as I think the world learned through Yellowstone.
Yellowstone, yeah.
Really, if you know that, you're ready to
You're good to go, yeah.
Yep, you're done. You're done. That's going in a nutshell.
Yep. 4 years, you don't need it, so.
Yep. So let's dive off into this uveitis.
Uveitis, so it's inflammation of the uvea, which is kind of what we call certain structures of the eye, which includes the iris, which is the colored part of your eye, the ciliary body, which is where there's a lot of inflow and outflow to the inside of the eye, as well as some muscles that control the pupil themselves. And then the choroid, which is kind of that like back layer of the eye before you get to the retina.
Yep.
And uveitis can actually be caused by a lot of different things. There's a lot of different inciting causes of the eye. I think everybody thinks about uveitis, they think of like kind of the big scary diagnosis, which is the recurrent uveitis, or the ERU or the moon blindness.
Yep.
That's kind of the one that everybody like automatically jumps to. But uveitis is like a really, really kind of broad topic, and there's a big like umbrella of things that can induce uveitis. Like probably one of the most common things is an ulcer.
Correct.
So any sort of, trauma to the eye itself is going to incite an inflammatory response. So we usually see in an acute ulcer presentation just a small amount of uveitis in the eye.
Right.
And usually treating it with, some banamine in the mouth or the vein, or just some topical stuff will take care of that. But when there's other causes, that's where we have to, do a little investigation and figure out where it's coming from.
So you got your old slit lamp out, you got your ophthalmoscope, you've got your window to the eye.
The eye.
What are you seeing in that eye that says, hey, I've got uveitis?
So what we call this haze, this like vitreal haze or an aqueous flare. And so basically what this is the white blood cells themselves that have now come into the eye and created this kind of hazy or kind of presentation. One of the things that kind of causes it too is that this blood ocular barrier, that's separating the eye from the rest of the body has become compromised. And so it's allowing these white blood cells to come in. It's also allowing a bunch of edema to come in as well. And so most of the time the call that we get is, hey, my horse's eye is blue and fuzzy, and it doesn't look right. And that blue color is caused by that edema that's coming in.
Yep, edema, the swelling, excess
Edema,
fluid. Is this the aqueous flare we talk about?
That is the aqueous flare. So when we're looking at it through a light, we almost kind of compare it to like when you're like watching like your headlights in your car, and you're going through like really dense fog, and it's just kind of reflecting back at you. That's kind of what it ends up looking like to us if you shine a light to it.
You know, a little segue. I've always the first time I heard the word aqueous flare, being older, and some of our listeners may remember this. There was a wrestler named Ric Flair. And he was on the WWF, and it was old Ric Flair. Now, first I heard aqueous flare, all I could think was like, that'd be a great wrestler name. Like, you had the nerd at WWF, like aqueous flare coming out, you know.
That's your wrestler name.
Yeah, that's my wrestler name. Let's go with that. Aqueous flare.
Aqueous flare.
I don't know, I just think it's a cool word. So yeah, aqueous flare. That's one of the first things. And like I said, a lot of the owners, blue appearance.
Blue,
my
yeah.
eyes hazy. Sometimes they're comfortable, sometimes they're not.
Sometimes, yeah, that's the hard thing about these too, is that sometimes you look at these eyes and the horse's eye is open and they're they're going about their regular life, but their eye is just blue, and it's weird. And sometimes they can see through it. A lot of times they can't. And so sometimes people will be like, hey, like it seems like they're kind of spooky on that side, or they're not able to do what they need to do because, like we talked about on the first couple episodes, the cornea is your windshield. And if there's a whole bunch of edema sitting in there and you can't see through it, they're not gonna be able to see. So.
And I think it's important when you see this, this is a good time to call your vet. Because as your mama used to say when you're growing up, you only got two eyes, you don't get any more. And I've got this thing, like, I don't like blind horses.
No.
Especially when there's stuff we can do. So again, if y'all have heard the podcast before, you're going to hear us talk a lot about call your vet soon, early intervention. And that's important here. We'll get into that later. But yeah, so we've got this hazy appearance. We've got some aqueous flare. The eye's not happy. We're like, what the heck?
What the heck?
Vet. We're going to come out. We're going to use the word like, hey, you got some aqueous flare. Another word I love that we'll often see. Now, this is kind of that later stage. This has been going for a minute, right? The old hypopion. Hypopion.
Ooh.
I will say this. Like, I'm a lameness guy. I'm a performance guy. But ophthalmology's got some of the coolest words. Hypopion.
Hypopion. So hypopion is basically that it looks like a big ball of pus almost just sitting in the eye, and it's just a bunch of white blood cells, and they tend to kind of collect like towards the bottom, like, so you think about it like a snow globe, and they all just kind of sit there at the bottom.
I just think like you got that one. You remember the one at the beach where it's got the sand that settles in the bottom?
Yeah,
you
yeah.
Rock it and you see the sand kind of move. The hypopion does that.
It does that. Sometimes you can see another little phenomenon called hyphema, which is blood in the eye. So it'll have a red appearance to it, and it kind of does that same thing, kind of settles more towards the bottom of the eye. But it can kind of come from anywhere. I mean, it can. Yep. That's a lot of times with these horses that get kind of blunt trauma to their eye, they smack it, maybe don't disrupt the cornea itself, but they get a big old bonk to the eye. You'll see the red.
Yep, hyphema, hypopion. Yep, those are definitely there, and,
right?
We try to catch these before we get to that hypopion stage. Sometimes we don't, because it can happen rather quick.
It can, yes, it can.
And I think that's the amazing part about eyes is, in other species, you got time. In horse eyes, like, it goes south quick.
Yes, it can. Like within a matter of hours. Yes. Sometimes that people are like, "Hey, my horse was fine this morning," and then all of a sudden their eye is blue and red and white and all the colors of the rainbow, and you're like, what the heck is going on?
Well, and I've had calls where I've been out to see a horse for something that morning and everything's fine, and then that night I get a call in emergency like, hey, he can't see well, his eye doesn't look, and I get there. We've gone past aqueous flare, and we got a hypopion settling out the bottom, and I was like, I just saw this eye 12 hours ago.
Right.
We were, doing a vaccine exam or whatever, and now I've got hypopion in the bottom of this eye. It happens quick.
It does. And the thing is too is that the eye doesn't like to have a bunch of inflammation in it.
No, it does not.
No, because again, kind of what we talked about in some of those first episodes, and we'll continue to reiterate, is that the eye kind of has its own like little micro environment. Yep. The eye doesn't really do a lot of contact with the rest of the body in a normal situation. It's when that, aqueous barrier gets disrupted that now the eye is, responsive to a lot of things happening in the body, and we've got all this inflammation in there, and the eye doesn't really know how to handle that. Like, it doesn't do a very good job of, regulating its own immune system. And so with all of these, white blood cells and cytokines and antibodies that are now floating around in the eye, that's going to start destroying all of those interior structures that we were talking about.
Right.
And so that's where, these repeat episodes of uveitis, that's where we, start to get worried about, these long-term effects of these things. And so we're like, we need to look at, is their eye comfortable? Can they see, what can we kind of do to help preserve this eye if we have one of these conditions where this is going to be a repeat thing?
Mm-hmm. Which, that's the biggest problem with horses in general, right? Sometimes it's not the condition, but it's the way they respond.
Mm-hmm. Exactly.
And unfortunately, is all our listeners, if you have horses, that gum wrapper can send them into a tailspin, right?
The plastic bag of death.
The plastic bag of death.
Uh-huh.
I mean, they freak out about everything. Well, it comes naturally to them because their immune system likes to freak out as well.
Yeah, exactly.
And that's part of what sets up for this uveitis, something that's small and not that big of an issue. And then, like we're going to talk about, corneal ulcer is one of the leading causes of uveitis.
Mm-hmm.
It's a small scratch to the eye.
Yeah.
And then they just explode and way overreact to this thing. And you're like, just calm the heck down.
Calm down, chill. It's going to be okay.
So, good news, horses come by this naturally. I mean, they freak out over the gum wrappers of death and the plastic bags from outer space. And their eyes, guess what? They freak out too. So,
right.
So that sets us up some factors that can lead to this. We're going to start with acquired issues first, and then we're going to talk about, unfortunately, the dreaded recurrent uveitis, which is a process unto itself. But a real common cause is that corneal ulcer.
Corneal ulcer is probably, I'd say, one of the most common causes of uveitis. If we had to look at every single thing that could cause uveitis, corneal ulcer, because it's a trauma to the eye itself, and the eye says, ooh, I don't like this, barrier gets a little disrupted, and now we've got tons of inflammation in the eye. Luckily, with this cause though, we treat it, we give the horse some Banamine or something to, kind of calm down inflammation, goes into the eye, calms it down, and, within a couple days, if that ulcer is taken care of and there's no infection, good to go, uveitis is gone.
And I think that's important. We talk about the systemic treatment. We talk about the Banamine. I think that's probably one of the most crucial things we can do is provide that systemic anti-inflammatory. And interesting enough, they've done a ton of different testing over the years, because when we look at the suite of anti-inflammatories we have for the eye, we've got Banamine, we've got Bute, and we've got Equiox. Banamine, for whatever reason, that is like
it's the only thing that works.
The eye likes Banamine. So
yeah, it's really the only thing that actually will kind of combat that uveitis. And they've done tons and tons of studies, and it's time and time again they're like, Banamine for the win.
And I find it interesting because these systemic anti-inflammatories, Bute and Banamine, the same class. Equiox, it's a COX-2, so it's a little bit of a different class. But they're all working on the same pathway. But yet, for whatever reason, Banamine says, hey, this is going to be better.
Right.
So
it's like the same kind of concept with yourself. Some things work better with Tylenol, some things work better with ibuprofen.
I found a miracle cure last week called Toradol.
Oh.
I had a little situation arise that landed me in the ER, and I got Toradol, which is an anti-inflammatory. It's magical for GI pain. I think it is the Banamine of the human world. So
today's episode sponsored by Toradol.
Yeah, today's Duncan and Toradol again.
Duncan and Toradol.
I still keep hoping Duncan's going to pick us up and be like, hey,
one day.
Yeah, we're going to provide coffee for all of your podcasts. So, but yeah, we got the scratch cornea, and the biggest thing there, right, is treat that cause, right? Get the ulcer under control, treat the uveitis secondary to the ulcer, and then we can get it to respond.
And then we can get it to go away and hopefully never come back.
Other causes, trauma to the eye.
Trauma to the eye. So, and a lot of times, blunt trauma to the eye itself, like, getting whacked in the head with a polo ball or, a branch or something, that can actually be more damaging to the eye itself than a scratch. Because it's that big blunt trauma and all that pressure that can dislodge things, that can, cause some structural damage inside, that can, cause the big bleeding in the eye, and that can actually be a lot worse than just a scratch.
Yeah, and horses like to run into things.
Oh, yeah. That's their second favorite thing to do.
Yes, when they have that plastic bag from the plastic bag of death, it's going to eat them. And the plastic bag doesn't cause the problem. It's the freak out moment where they decide to run into something, and then we have blunt force trauma leading to that uveitis.
Right.
And we've got to early intervention, getting that under control as soon as possible is really, really important. So that kind of leads us into, those are the basic things that can cause this, but we get into, I guess we're kind of moving into that recurrent, which I guess before we get into that, let's talk about different systemic infections that can actually cause issues with the eye. Your horse could pick up a virus or even a bacterial infection that has absolutely nothing to do with the eye. It can be a respiratory infection, a GI infection, and lo and behold, we're headed down to uveitis land.
I mean, at this conference I was at, they were even talking that one horse had a pretty big foot abscess.
Oh, wow.
A foot abscess, and then all of a sudden the horse was getting uveitis at the same time while going through that. So anything that's really causing a bunch of inflammation in the body. So, viral causes, we think of equine herpes, equine influenza. Those are two, common respiratory pathogens that those are known to do that. Salmonella or a lot of the GI issues, like big, really bad colitis, those can, incite that as well. And then we get into bacterial infections, and probably the most common one that we think of with bacterial is leptospirosis.
Oh, lepto. Lepto is, if I had to pick all the bacteria that are the biggest thorn in my side, lepto, because I swear, the more we learn, the less we know.
Yes, pretty much.
I think every time I read a new paper on lepto, I'm like, finally I'm going to learn something. I just got a million more questions. But,
exactly.
Lepto, big issue.
So lepto is a bacterium, and it's basically spread through urine contamination. And so it's, most of the common times that we're seeing it is, horses and dogs that are drinking out of ponds, streams. It could even just be in their own water itself if it's being shared by lots of critters on the farm. So that's where they tend to get it, and it causes a lot of different issues in the body. The uveitis is kind of the one big one that you see, but it can also cause abortion and in pregnant mares. That's another big kind of thing that we see, but
difficulty just getting mares in foal as well.
Yes. And the problem with lepto too is that you can treat it with antibiotics. Usually it's, doxycycline or Baytril or, one of those. You can treat it, but they can still continue to shed it. Even after you've treated it.
Yeah, it didn't really clear.
No, it doesn't. And there is a vaccine for it for horses. But there was actually a very recent test that came out that they presented at my CE, and they were like, it doesn't help with the uveitis.
Yes.
Unfortunately, they're like, it doesn't help with the uveitis. It just kind of decreases the amount that they're shedding back into the environment. But yeah.
And I think when we get into lepto too, what I've seen is it seems to be a farm problem.
Very commonly.
Because deer are a big reservoir for lepto. But I think there's more to it than that, because it tends to be, we see it in farms. Certain locations have more issues with lepto than others. And when we try to dig in and figure out how to prevent or why, we try to figure out what we can do to solve this puzzle. I feel like every time we run into a dead end, like you go look at it and it's like, all right, there's not a stream, there's not a pond, there's none of these issues that predispose us to lepto. And right down the street, they're not having an issue with lepto. And here they are having an issue with lepto.
Right. And a lot of these ocular signs, too, they don't start until like months after that initial infection. Like, so this thing can be dormant for a long time.
Yes.
And so, you may have a horse that shows up from another facility where they picked it up at, and then, they've been gone from that place for months, and now they're like, what the heck is this? And no one else has it. It's
and trying
weird.
to test, like if you want to go in and try to test to say, all right, before this horse comes in, before I bring him on property, what's my risk of lepto? Our test sucks.
Yeah.
Like we don't have a great one.
No.
Intermittent shedding, we don't know when they are. Antibody titers don't really help us with lepto. We beat our heads against the wall a lot with lepto. Other causes, thankfully, we don't deal with this down here, but for our brethren in the Northeast is Lyme.
Lime's another big one. And again, it's kind of that dormant, like they'll have it, they'll go through their kind of initial systemic thing, whatever, and then a couple months later, the eyes will flare up. You're like, what the heck?
Well, this is one good thing. Like we may have our own issues down here in the South, but one of the things I love is we don't have to deal with Lyme or anaplasm.
Like not for now.
No, for now.
For now.
Luckily our brethren up north, they get the Lyme and the anaplasm. We just have Pythium and fungus. So, but yeah. So we're dealing with Lyme. A lot of that we want to link to, or not Lyme, lepto gets linked to the equine recurrent uveitis.
Yes.
So let's kind of dive in. What is equine recurrent uveitis? The moon blindness.
Yeah. So this is more of kind of an autoimmune thing than anything else. So when we think about uveitis, you have a couple of different categories. So you have your acute uveitis, which they show up, they do their thing, we get it treated, it goes away, doesn't come back. And then you get more into your kind of chronic uveitis, which are, you have a bout of it, kind of goes away or tapers off, and then it comes back. So these like recurrent uveitis are these more chronic things that we're seeing at least 2 to 3 episodes of repeat offense. So it'll flare up, and then it goes away for a bit, and then it comes back, and it's a little bit stronger this time, and then it goes away a little bit more, and then it just kind of continues. So it's this very almost like insidious onset.
So like the name says, it is keep happening again. It's recurrent.
Exactly. So
they get to have one bout. But when bout number 2 shows up, we're headed to ERU land.
Right, and ERU too. It's I don't want to call it a diagnosis of exclusion, but in a lot of these guys, it ends up being one because, if we were seeing a horse for uveitis and we're seeing it for at that point the second time, we say, hey, you've had 2 bouts of uveitis kind of close together, like within a couple months of each other. We're going to start, just doing some more diagnostics and saying, hey, could this be lepto? Could you have had, an exposure to a respiratory thing? Could you have something else kind of internally going on that, we need to deal with that and kind of fix it? And so if we start going down that list and we're checking off all the boxes and we haven't been able to find that, then we'll start going down the ERU route, which is not the route that we want to go down, but I'd much rather find something that I'm like, ooh, we can treat that, we can do some things. But if we can't go down that, then we're going to be, thinking more about ERU. And we've got some kind of poster children for it too. Appaloosas in general are like 8 times more to get any sort of uveitis from, and that's not just the ERU, it's anything. Right. So if, even just a colic, they're more likely to get a bout of uveitis from that.
I tell people with apps, like a lot of times it's not if, it's when.
Yes. And
I think it's important to know these things. When certain breeds are predisposed to things, I think you need to be aware. Like you need to be aware, like apps, if you own an Appaloosa, be aware that ERU is probably coming.
It is.
And the sooner we find it, the sooner we start treating, the less damage we have to that eye. So knowing you have that, remember those signs, the cloudiness, the haze, the blue appearance, painfulness to the eye. Let's get the vet out and let's get this checked.
Right. And again, and it can be very, very subtle changes too. I mean, the first thing you may even notice is that there's some changes to their vision. You're like, hey, they seem like they're a little more spooky on one side of their body.
Right. Good point.
Or, they seem like, they're having trouble getting around at night or something,
Right.
like they're bumping into things. So you're like, maybe this is something to look at. Because again, these uveitis, like when this inflammation shows up, sometimes they're not painful.
Well, and I think this also falls in that category. ERU sees us more than we see it. I think a lot of times when we get this diagnosed and we start digging into the history, a lot of owners are like, you know what, nighttime has been tough. He's been just bumping into things. I thought it was he wasn't paying attention. Or, you know what, when we're dealing with shadows, he's a lot more spooky dealing with shadows than he has been. I just wrote it off to this.
Allergies. I feel like a lot of these horses that have allergy eyes are just very early uveitis horses.
Yes.
And and it's not to say that there's no such thing as allergy eyes. I mean, they do happen. Like it is a thing, but when it's just kind of continually coming on, and it seems like all of a sudden it's getting worse and worse, and we're doing things to treat the allergies and we're not seeing results, that's where we're like, something isn't right.
Yep.
Something's not right here.
When we look around, like, it's the middle of December. There's not a lot of allergens floating around.
Right.
And we're dealing with an allergy eye. We're going to go down the ERU route.
Yeah, exactly.
And like I said, it's not the end of the world. We'll talk about that later. It's not the end of the world, but the sooner we get to it, the better. Gold standard for getting this diagnosed, let's talk about interocular pressure.
Yep. So interocular pressure is it's what it sounds like. It's a measure of the pressure in the eye. And when there's a lot of inflammation in the eye, the ocular pressure actually goes down.
I know, isn't that crazy?
It's weird.
Yeah.
But yeah, it is. It's weird. We don't know why it does that. But so that's one of the things that you may see us do when we're doing a really thorough optho exam, is we are taking a pressure. And there's a couple different tools that we use, and it's basically like a little it's like a little there's like a little ball that kind of goes like doop 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 doop, and it rebounds and tells you what the pressure is.
Very similar. If you've been to an ophthalmologist and you've been checked for glaucoma, it's a very similar instrument to that. They got a cool one that kind of swings into position. Ours, we have to hold still because we don't have the cool swinging into position.
They did mine the other day. They were just blowing air into my eye
They
repeatedly.
use an air pressure.
The air pressure, that was the one they did for me the other day, and they're like, you keep blinking. I'm like,
yeah.
Can you block me or something, please? Like, it's like my horses get blocked when I do this. Like,
yeah, we just put a topical anesthetic on the eye. They don't feel this. It's not uncomfortable. We do these readings. We get a lot of information from that. The magic number in ophthalmology is always 20.
Always.
It's always 20 plus or minus 5. Shimmer tear test, interocular pressure, 20 plus or minus 5. So you'll see us take these measurements. We're going to take multiple. If that pressure's low, we're dealing with uveitis. And it's a matter of why do we have uveitis.
Right. So. And then kind of on the opposite end of that, one of these changes that you can actually see in these guys if they've been having ongoing uveitis for a long time is they'll develop glaucoma.
Yes.
And so it's kind of one of our end stage uveitis markers is there's so much damage now to the eye that it's just not regulating pressure as much, so you actually start to see that pressure go up.
Yep. Increased pressure, that's glaucoma. And that's the goal of the early intervention, early treatment, strict management. We can do a lot more for uveitis. We get into glaucoma land, and glaucoma we do not have. Unfortunately, we don't have as much we can do. So that's why it's important. And you get into chronic conditions here, it's very important for you as the owner to keep these treatments going. Even if the eye's comfortable, we may say, hey, you're staying on this medication.
Right.
Even if the eye's comfortable, because we're doing all we can to prevent us from getting into glaucoma. Because once we get to glaucoma, we're really limited. And I think glaucoma, I've seen it is very, very painful because those pressures, I've seen them as high as 110.
Yeah.
And I mean, you imagine that much pressure in your eye, that's miserable.
Yeah, it's painful.
So
and because we don't really see primary glaucoma in horses like we do in like dogs and people. It's just it's always more of a secondary thing, and so a lot of these a lot of these glaucoma medications that we have available to us, they just don't work because it's not. It's not the same disease. So
I know there's differences in that. I probably should have looked this up for the podcast. I can never remember it. There's narrow angle and wide angle glaucoma.
Yeah.
And whichever one horses get is which one do they get?
Oh gosh.
All right, so y'all stumped us on the podcast. We can't remember the.
We can't. But again, it's something that we just don't see it.
No, we don't
until
see
you're
it.
at the end and you're like, all right, we gotta do something. We gotta make a decision here. So.
And unfortunately, we can't really treat it. So.
And then other kind of long-term things that we see with these chronic uveitis horses, cataracts is a big one.
Cataracts, yep.
So cataracts are basically a kind of increased deposition on the lens capsule itself, and so this kind of continued inflammation that's going in there causes these cataracts to form, and a lot of times that's where the first kind of vision changes start, is because now they've got this thing on their lens and
it's
they can see through
it. It's like having a film over your eye.
It is,
it's
yeah.
It's really cloudy. And in people, we can do lens replacements. A lot of people have had that done. They work great. Horses, yes, it's an option. Is it a good one? No. I think the ophthalmologist will try to talk you out of it. It's just not a great outcome. So let's don't get that cataract.
Don't get that, right. Other things we see too, this is where some of my favorite words come in. So synechia is one. So this is where you start to get some destabilization of the iris itself, and it actually adheres to either the cornea, which we call an anterior synechia, or it adheres to the lens, which is called a posterior synechia. And so what this looks like is basically you see their pupil, and instead of being more kind of an oval shape, it just kind of starts to deform and long term.
It's symmetric.
Yeah, they're and they just, you look at them and you're like, that doesn't look right. And you're like, something's not right here. And basically what that does, the more it starts to happen, is now the eye can't, or the pupil can't constrict and respond to light. And so these horses get almost really light sensitive because now they're outside and they're like, ugh.
My eye doesn't work.
My eye doesn't work. Or the opposite, they're in a dark room and, they can't open up their pupil more than they should, and now they can't see. So
let's talk about, unfortunately, we've talked about all the bad.
We've talked about the bad, yes.
But let's get some hope. There is some hope. We get this diagnosed. We've got some options, right? Let's talk about how we're going to approach uveitis treatment. Let's talk about some of the options we've got.
Yeah.
Start with simple, and then let's kind of ramp it up from there.
So our goals really are, we want to find the cause of this inflammation if there is one, and get that treated at first. So if it is, lepto or Lyme or one of these things that we can treat, get that treated.
Systemic antibiotics,
and systemic anti-inflammatories as well, because we need to control wherever that inflammation is coming from.
And one of the things we didn't mention earlier, sometimes tooth-root abscesses can cause enough inflammation. And I've actually seen that, where a tooth-root abscess was setting us up for this uveitis. Again, if we don't get that addressed, we're not getting rid of the
uveitis.
So let's get that addressed.
Right. So systemic anti-inflammatories. So, like we talked about, Banamine, awesome.
Yep.
And just as a note, Banamine cannot go into the eye.
Yes.
Banamine is a systemic. It cannot be put topically into their eye. It will burn, so please don't do that to your horse.
Unfortunately, we have seen that mistake happen.
We have seen it, so.
Let's don't do that.
So
that's our PSA for today. No Banamine in the muscle, and no Banamine in the
eyes.
eye.
So, yeah.
And Banamine works great orally.
It does, yes.
It works fantastic orally.
The injectable Banamine, you can put that into their mouth. You can squirt it into their mouth, and it works just as fine. So.
And to give you an idea, just in general, it's going to take about 15 minutes longer to work if you give it orally versus injection.
Correct.
That's not a lot, guys. We always got 15 minutes.
Right.
So oral NSAIDs.
Oral NSAIDs.
Every once in a while, we have to go to the corticosteroid, right?
We can,
Start getting the dexamethasone.
For especially these really, really painful causes, if there is a lot of inflammation and they're a little more painful, we will reach for a steroid. We will, in your typical ophthalmology exam, It's getting to me today. In our typical optho exam, we will stain the eye too, just to make sure that there isn't a corneal ulcer, because again, as we learned in our previous episodes, corneal ulcers and steroids do not go together. So, you know, we'll make sure that we're not dealing with that before we reach for the steroid, but that can also be a good option.
Topical medications, we're going to put you on some of those. Big one's atropine.
Atropine is great. So atropine it's a drug called a mydriatic, which means that it dilates the eye, and that just helps with kind of drainage in the eye and getting all of that you know, inflammatory molecules out of the eye. Just
remember, if you're on atropine, your horse is gonna need some sunglasses. They got some great ones out there, the Equivisors. They've got tinted lenses. UV block and fly mask, mainly because that eye is dilated.
Yeah.
So bright light's going to be rough on them. So we're going to talk about some kind of a mask when we do that.
And a lot of times, one dose of atropine will dilate their eye.
Yes, for days.
For days. So, you know, I tell a lot of people that, you know, once our eye is dilated, we don't have to keep doing the atropine every day. A lot of times if I'm treating these horses chronically, I'm like, hey, we can do this, you know, every other day, or sometimes even every 3 days.
Right.
Because as long as their eye is dilated, it's like, we're good. We do not need to keep throwing this at them. So.
And that's great. Acute management, definitely grabbing the atropine. What are some other meds that we may use in the acute stage? And then we'll kind of get into chronic management.
So topical NSAIDs or topical steroids are great. So for steroids, we've got dexamethasone is kind of our go-to. So it's usually, at least in the form we provided, it's also kind of bundled in with the triophthalmic ointment, so the Neopolybac. That's a great one. You'll see topical prednisolone, topical hydrocortisone. Those are just to kind of name a couple. And then for NSAIDs, diclofenac is usually our go-to for them. So it just kind of depends on how well the horse responds to it. You know, I'll usually reach for a steroid first, because I like to hit them kind of hard, especially in that more acute phase. And then as we are getting into more of a just kind of everyday management, then we'll go to more of an NSAID.
And especially when your horse is on a steroid, do not be afraid to call your vet and ask questions, because when we go the steroid route, because some of these horses with uveitis are a little more prone to corneal ulcers.
They are.
If you're on a steroid, if your horse has got a steroid going in its eye, and if you notice one of those change, pick up the phone and call. Do not let this drag on. So I always say, when I start an optho case, we're going to get to be friends.
Yes.
Because we're going to talk a lot.
Yes.
Until we get things kind of stabilized. But at first, there's a lot of conversation.
There are.
Be sure to call if there's a question.
Right.
Call your vet.
So those are kind of our you know, our kind of basic, like, hey, we're going to start with this and go forward with that. And if we, you know, could get the inflammation under control in that acute stage, now our, you know, kind of next goal is, all right, how do we keep this horse comfortable and try to, you know, decrease that amount of time, decrease the number of recurrent episodes that they're having.
Long-term chronic management.
Long-term chronic management, yes. So a lot of these horses, we will keep them on a, you know, daily diclofenac or daily NSAID. So, you know, just putting it in there once, twice a day, just to try to keep it at bay. And even, you know, one thing I don't think we mentioned is, a lot of times this disease presents with just one eye, but more than half of these horses, the disease will end up becoming bilateral at some point. So even if the other eye isn't showing any signs at that point, you know, we may say, hey, let's start to just, you know, maybe treat the other eye once a day, just as a precaution. So it's not uncommon that we will do that.
Now, cyclosporine. Where does that fit in? Topical cyclosporine.
So topical cyclosporine, the brand name is called Optimmune. So this is an immunomodulator. So it's a little bit different of a drug. It's not going to directly treat the inflammation, but it's going to kind of act more as, you know, give the eye a little bit better of an immune system itself to kind of defend itself from all of these causes of inflammation. And so that is when we do start this, you know, kind of long-term management of them, we will put them on this cyclosporine to, you know, just kind of help them out a little bit. And we have been able to see that putting them on this can kind of prevent that, recurrence of these, more frequent diseases. And, we can do a topical version of it. A lot of horses respond well to that. But the other kind of newer thing that we do is an implant.
Right.
So this is where they put just a little device kind of up in their sclera, and it just releases a very slow kind of trickle into their eye directly.
Really effective.
Very effective.
Very effective.
Very effective.
Where my decision tree on that is if they're maintaining well on topical cyclosporine, then that's where we start talking about that implant. I mean, you can get 4 years out of this implant.
Yeah.
So I mean, 4 years of cyclosporine, where you're not treating this every day. And that's a huge benefit.
Yeah, absolutely.
The eye's happier. The owner's happier.
Yes.
Because you're not out there once or twice a day putting
cyclosporine in their eye.
So, and speaking of cyclosporine, that's one thing I want to mention. It's an interesting drug in that we have generics, but cyclosporine is one of those that we grab the name brand.
Yeah.
For whatever reason, with cyclosporine, the Optimmune works. Generics just don't. We just don't see it. So we're gonna go name brand on that.
Yep.
Name brand's important. Generic, you're just wasting your time and money.
Yeah. Right.
But yeah, the cyclosporine implants, fantastic. We will, in our practice at least, we're gonna send you to see an ophthalmologist to get this done.
Yeah.
We've got some great ones that we utilize, but very, very effective treatment. I've been very pleased with it.
Right.
Been around for probably 10 or 12 years now, and it's a really good option.
Really good option, right? If they're responding well to it, you're like, yeah, let's go for it. And again, it's important to remember with this is that, this is a chronic disease. Like, we kind of base our success on, can we prevent them from having these recurrent episodes? Right. But eventually they probably will succumb to this disease. It's just kind of inevitable, it's not something that we can cure them of. So, as we're going through, it's going to be, like you said, really important to continue talking to your veterinarian and say, hey, we've been doing the cyclosporine for a couple of years and it's doing really well, but now we're starting to get some more breakthrough episodes. So what are some, kind of longer term things that we can do?
Well, and one of those, and I think this is one of the most interesting things I've seen with uveitis treatment, because we got no idea how it works, why it works. Intravitreal injection of gentamicin. So we actually inject the back of the eye with gentamicin. I know you just got back from an ophthalmology CE. Any new news on that front about how it works, why it works, success rates? What are we looking at?
They still don't know why it works. It is, from my understanding, it's a little bit more of a Hail Mary.
Right.
So if you've been, kind of treating these guys and they're not responding to your NSAIDs, either systemic or topical, you've done all the things, you can't really stop that repeat episode. Sometimes this is something that you can reach for and give it a shot and see if it works. It may work. And again, we don't really know why. It's not a permanent cure, but it can a lot of times at least calm them down for a little bit, keep them comfortable. There is a risk that they can just go acutely blind, even if you've done the procedure like 100% accurate. If you've gotten exactly where it's supposed to go, sometimes they can just go blind. So that is a risk to know if that is presented to you as an option. But again, if we're going down that route and we're just looking for something, it is something we can try.
Right. If we're not winning, let's go for it.
Right.
But yeah, that's always been interesting to me, is that we do this and we have no idea still how it works, why it works. But I can tell you, I've sent a couple horses to ophthalmologists. They've had this procedure done, and it's been really successful. And so it's definitely on that list of things that your veterinarian may talk to you about. Is getting that, getting that intravitreal gentamicin.
And again, the one thing that, if I do diagnose one of these, recurrent uveitis is I always tell the owner up front, hey, eventually we're going to go blind. Unfortunately, we can do everything correctly, and eventually the horse is going to go blind. And it's whether it's from the cataracts that they develop, or, their retina degenerates or detaches. That's usually like one of our most common causes, but eventually they're going to go blind.
Or the secondary glaucoma.
The secondary glaucoma. It's one of those usually ends up being the inciting cause. And I think a lot of owners, kind of panic when it comes to, oh my gosh, my horse is going to go blind.
Yep.
It's not a, one day they can see and the next day they can't.
Right.
It is a progressive thing that happens. So, a lot of these horses, by the time that they are completely blind, they've kind of adapted to it a little bit. And so that is, kind of one thing that I talk to owners about when we talk about, hey, your horse is starting to go blind. What are some things we can do? And horses can actually do really well if they're blind. They can, they can get around okay if, you want to keep them in a familiar environment, if it's one-sided blindness, always, make sure that they know you're there, kind of touch them and talk to them and, keep the environment familiar, don't plant any new trees out in the pasture or anything. They might run into them, but they tend to do really well.
They do.
If they're in a familiar environment. Sometimes too, they'll use their herd mates to, kind of be a little guide buddy. You'll notice your other horse kind of stands on their blind side and kind of acts as a buffer between them and the rest of the world.
It's really cool to watch how they'll take care of each other.
They do, yeah. Really, that herd instinct comes in.
Yes, it's kind of like their seeing eye horse.
Yeah.
And that is the downside. But, at the same time, I mean, we do know that's where we're going. But I can tell you with a lot of the treatments that we have today, that time from diagnosis to that end stage uveitis, it's getting longer and longer.
It is,
and we're
absolutely.
getting more and more successful, and we're learning every day. Like, you got back from the CE, and there's a lot of things that are out there, and a lot of treatment options that didn't exist a few years ago. And so I think it's very important to get the early intervention and do the things correctly and do them right.
Right.
And we can really postpone the eventual, unfortunately, inevitable outcome. So I think there's a lot of good things, and there's more on the horizon. I mean, they're working every day on this, so.
They are. It's, again, because it's such a common disease, and
Yes.
I think it's just a matter of saying, hey, let's get on this now. Let's know the expectations and, get aggressive with it early and, be kind of be ready to commit to this and do what we need to do.
So great topic today.
Yeah.
Lauren, thanks for sending the question about uveitis. Forgot to mention that earlier. Lauren, one of our listeners, sent this in. So it was a great kind of deep dive into uveitis. Thanks for tuning in. Dr. Brown, thanks for being here again this morning.
As always.
Again, keep sending your questions. Keep sending your things you want to know about. We love doing this. We've had a great time doing it. We're going to keep it up. So, all right, we'll see y'all next week. Thanks again for turning to the Equine Vet Connect, and we're here to help you in any way we can.
Bye.
Thanks.